Welcome to Academics. This is a tutorial on the art of history taking, particularly the surgical patient. So I'm sure you've heard the saying that you do not clerk a patient, rather you clerk the condition with which they are presenting. So the goal of this tutorial is to highlight the fact that you need a template for each condition that comes to surgery. The way you would talk to a patient who comes in with peripheral vascular disease is different from a patient who comes in with a malignant pleural effusion. It's different from the way a patient who has got breast cancer presents. And you need to make a template for each condition that comes. Today we'll be making a template for a patient who comes in following trauma. So the presenting complaint. Many students seem to be scared of giving a simple presenting complaint. Chest pain, dyspnea, hemoptysis. These are examples of simple presenting complaints that can come in the respiratory system. Inability to bear weight, loss of consciousness, limb weakness, and a wound. Just a wound can be a presenting complaint. And then students will ask, but how do we know how many presenting complaints that you can give? I would say to avoid confusion, you need to have a minimum of a maximum of one positive finding for each system that you meet. For example, in this example, if the patient has got chest pain, dyspnea, and hemoptysis, you could take the dyspnea and you make the chest pain and the hemoptysis associations of the dyspnea, and you would go on to find the other positives in the other systems. So this won't confuse you when you are expanding on the presenting complaints in the history of presenting complaint. So the history of presenting complaint, simply put, this is an expansion on the presenting complaint. How did it happen? When did it happen? And how has it progressed over time from the insult up to now? So the mechanism of injury is very important. How did this happen? This is a patient who was involved in a road traffic accident as an unrestrained passenger in a small vehicle which collided with a bus, and the patient was thrown out of the bus. And this is the mechanism of injury. And you can tell us that the patient was the most seriously injured of all the patients, of all the people who were involved in the accident. This will give us an estimation of the force that was involved in the accident. It will tell us the other injuries that we can anticipate from this patient. You can tell us that it was a fatal accidit, 4 people died, and then people will know that this was a serious injury and the force was great, and you would expect, in management, you would expect other injuries to be there in the patient. It is also important to know the chronology, the order in which the symptoms appeared in the patient. Just because the symptoms happened out of trauma, it doesn't mean that all of them will appear all at once. So you could have a patient who had chest pain, but it progressed and the patient later developed shortness of breath a day after. It is very important to highlight that they had chest pain initially, and then a day later they developed shortness of breath. I always give the example of the patient who loses consciousness soon after an accident. So the patient loses consciousness soon after an accident, and then they present to the hospital with chest pain. So when you're giving the chronological order of this patient, this is a patient who was involved in an accident, and then they lost consciousness. When they regained consciousness, they had chest pain. This is the order in which the patient noticed the symptoms. So the chronology matters. So whenever you mention a symptom, you need to do a Socrates of it. If there's pain, you're going to do a Socrates of it. But there are other symptoms like bleeding, like shortness of breath. When you do a Socrates of those, it just means that you are exploring them to the fullest. If the patient says they were bleeding, you need to tell us the bleeding to the fullest. You need to tell us the amount of bleeding that the patient experienced. If the patient has got shortness of breath, you need to characterize the shortness of breath. Was it associated with inspiration? Was it associated with a cough? Did anything relieve it? So it could not fit the Socrates to the fullest, but it doesn't mean that you cannot explore something down to the last detail. And the systems review. So a systems review is the centerpiece of this artwork that we call history taking. Why? Because in a systems review, a student is seen to be taking a history that is particular to the patient. The examiner, if you give a good systems review, the examiner can tell that you know that a trauma patient will present differently from a patient with diabetes. So with the systems review, the trick is that whenever you say something in a systems review, if the examiner was to stop you and ask you, why were you asking that? You should be able to justify it. I'll be giving examples. You should be able to give a justification why you would ask such a thing in a patient who is presenting following a trauma. So for example, the CNS. If a patient is coming to you and they've got chest pain, all right? The patient has got chest pain, they've got hemoptysis, all right? Yes, but this is a patient who was involved in a road traffic accident. What other things do you expect to find in this patient? You could expect to find them with loss of consciousness. You could expect to find them with neck pain. You could expect to find them with seizures, limb weakness. Do they remember the events? Do they have amnesia of the events? Do they have headache? Do they have vomiting? Yes, vomiting is a symptom in the CNS because it could point to raised intracranial pressure. Do they have rhinorrhea? Do they have otorrhea? Do they have vision change? So these are the things that could happen to a patient who has been involved in an accident in the CNS. If an examiner was to stop you, why would you ask vomiting in a patient in the CNS? You tell them, I'm anticipating that the patient could have raised intracranial pressure. Why are you asking about rhinorrhea? Why are you asking about otorrhea if they have basal skull fracture? Why are you asking about seizures? In trauma, patients can have seizures. Loss of consciousness. It could happen to a patient with raised intracranial pressure. So these are the things that you ask. So in the musculoskeletal system, does the patient have backache? Do they have neck pain? Do they have limb paresthesia and weakness? Do they have limb pain? Do they have inability to bear weight? And do they have obvious deformities? Do they have any wounds or any bruises? So if the examiner stops you, you will tell them that I am worried about a patient who will complain about neck pain because the C-spine is very fragile. You could tell them that I'm worried about a patient who will complain of backache because that could signify a spinal injury. And then the genitourinary system. Students seem to have some trouble tying this system to trauma, but it's very simple. What things could happen to the genitourinary system in trauma? You could have bladder injury, you could have urethral injury. So with bladder injury, how does it present? You know there's extraperitoneal, there's intraperitoneal. But basically how they present is that you could have bladder injury and then the patient does not pass any urine. You could have urethral injury and then you notice blood at the meatus. So if the examiner stops you and say, why are you asking about blood at the meatus? You tell them that there could be urethral injury that can give you blood at the meatus. If the patient has been anuric since admission, you need to know that because that's how a patient would present if they had bladder injury. Do they have symptoms of incontinence? Because with spinal cord injuries, you could have symptoms of incontinence. This ties both neurological as well as genitourinary system. So with Cauda-Equina syndrome, you could get incontinence. If the examiner stops you, why are you asking about incontinence? You should be able to say they could have Cauda-Equina syndrome. They could have spinal shock. So in the CVS, if the patient is bleeding, quantify the bleeding, okay? Don't let the patient guide you to say, I had bleeding of a bucket full of blood. No. You should use things that will give a full description. You could say that the patient's clothes, all the patient's clothes were soaked in blood. That's a good description. And the examiner will know that what you're talking about, the patient lost a significant amount of blood. How long, after how long was the bleeding stopped? With what was it stopped? How much effort did it take to stop the bleeding? Do they have any symptoms of anemia after the bleeding was stopped? In the GIT, what could happen to the GIT? If you have injury to abdominal viscera, you could have a rupture of abdominal viscera and you could get peritonitis. You could anticipate abdominal pain, peritonitis. And if there is a stab to the lower abdomen, to the lower chest, to the upper abdomen, you could have a patient with hematemesis where there's stab to the stomach. So these are the things that you ask in a patient with trauma. They are different from the things that you would ask a patient with peripheral vascular disease. In the past medical history, this is a surgical patient. You give us things that are relevant to the patient, and you don't have to dwell too much. If there's nothing, then there's nothing on this system, on this topic. So your diabetes, your epilepsy. So epilepsy, for example, would be particularly useful or very important in a patient with head injury. If we see a patient with head injury and they are having fits, and they could be an epileptic patient and it wasn't mentioned in the history, then you see that it was important for the student to mention. A patient with asthma and they've got blunt chest trauma, it could be hard for us to wean them off oxygen because they are already asthmatic. Their respiratory system is already hypersensitive. So does the patient have bleeding tendencies? Do they have a drug history of drugs that could be important in our management, that could interfere with our management? Do they have any allergies? The surgical and anesthetic history. And I say it again, surgical and anesthetic history. As someone who has passed through a hospital, you should be different from those that haven't. When you say surgical, you should say surgical and anesthetic history. Does the patient have problems with surgical and anesthetic history? At any point in their life, did they go through an operation and there was a problem with the anesthetic team? You should know that, because this is a patient who's in the surgical ward. They might need to undergo surgical treatment again, and anesthetics could be a problem. You need to ask that. So the social, okay? You need to treat the patient in front of you, their social life. The one patient that is in front of you, don't give a generic social history. You should give a social history that is relevant to the patient that is in front of you. For example, if a patient was injured in a bar fight, was the patient drunk at the time? Does the patient have behavior that is putting their life in danger? Are they drinking to the point of putting themselves in danger? When they were involved in an accident, were they drunk at the time? Does the patient operate heavy machinery and they have a drinking problem? Do they have any illicit drugs that they take? Were they high when this accident happened? The family support as well. Is the patient the breadwinner? It is very important to know that this patient is the breadwinner. And you could also ask the religious beliefs of the patient. You need to tell us if the patient has got any religious beliefs that could stop them from receiving a blood transfusion. Because with trauma, the patient is likely to lose blood. With trauma, the patient is likely to go to theater for treatment. And in theater, they might need a blood transfusion. So these are the things that are important in trauma in surgery. Don't just ask a social history to say they use modern methods of sanitation. The question of modern methods of sanitation, it's relevant for certain conditions. If a patient is presenting with diarrhea, then yes, you can ask that. But in a trauma patient, that is not very important to know. What's important are these things. You can add others, but they need to be relevant to the trauma patient. And then on examination, when you examine a patient who is coming in following trauma, you need to tailor your examination to the system that was affected. If someone has got a broken lower limb, you need to start there. Your examination should start in that lower limb, and you examine the neurological, the vascular components of that limb that has got a fracture. So it's going to be different from someone who's coming in with diabetes. If someone has got blunt chest trauma, someone has got penetrating chest trauma, you need to be seen by the examiner to be exploring things that could happen in a patient who has got blunt chest trauma, penetrating chest trauma. They should see you eliminating the possibility of cardiac tamponade. You should actually bend them together and say, the patient did not have any muffled heart sounds. The patient did not have any, does not have hypotension, and the patient did not have raised JVP. Then the examiner knows that, oh, this student was looking for it. This is examination that is relevant to the patient that is in front of you. I hope this video was helpful. Thank you very much. See you next time as we explore the history taking for a patient with peripheral arterial disease. Goodbye.